Welcome to Module 7 of Regenerative Orthopedics for Arthritis. Today, we synthesize everything you've learned into actionable clinical protocols, transforming knowledge into patient outcomes. You've mastered the SignalOme paradigm, molecular staging, platelet therapies, advanced biologics, adjunctive treatments, and precision delivery. Now we orchestrate these tools into personalized treatment algorithms that restore joint health. By the end of this module, you'll confidently select appropriate candidates, design stage-specific protocols, integrate voltage therapies, and navigate the complete patient journey from evaluation to regeneration. Section 1. The Comprehensive Evaluation Framework. Successful regenerative orthopedics begins before treatment with comprehensive patient evaluation. Not every patient is a candidate, and selecting the right patients determines your success rate. Modern evaluation rests on 3 pillars: structural assessment through imaging, molecular profiling via biomarkers, bioelectric evaluation of cellular voltage. Together, they create a complete picture. Begin with targeted history, duration of symptoms, acute responds better than chronic. Previous treatments, multiple steroid injections impair regeneration. Activity goals, marathon runners need different approaches than sedentary patients. Systemic factors, diabetes, autoimmune disease affect outcomes. Physical examination reveals mechanical factors. Range of motion indicates capsular involvement. Crepitus suggests cartilage damage. Effusion indicates active inflammation. Stability tests reveal ligamentous compromise. Each finding guides treatment selection. Pain patterns provide diagnostic clues. Morning stiffness suggests inflammation, responds to A2M. Activity-related pain indicates mechanical dysfunction, needs structural support with HA. Night pain suggests advanced disease, requires aggressive intervention. Section 2. Imaging and structural assessment. Each imaging modality provides unique information. X-rays show bone changes but miss early disease. MRI reveals soft tissue and cartilage detail. Ultrasound assesses synovitis and guides treatment. Choose based on clinical questions. Remember X-ray limitations. Kellgren-Lawrence grade 2 might be molecular stage 3. Normal X-rays can hide stage 1 to 2 disease. Never rely solely on radiographs for treatment decisions. MRI provides regenerative roadmaps. T2 mapping quantifies cartilage quality. Subchondral edema indicates active pathology. Synovial thickness correlates with inflammation. Meniscal status affects prognosis. Ultrasound offers dynamic assessment. Measure synovial thickness over 3 millimeters. Suggests inflammation. Assess cartilage thickness and quality. Detect effusions missed on exam. Power Doppler reveals active synovitis. Advanced techniques provide molecular insights. T2 mapping correlates with proteoglycan content. D-Gemeric assesses glycosaminoglycan distribution. These predict regenerative potential better than standard imaging. Section 3. Molecular profiling and biomarkers. Molecular profiling revolutionizes patient selection. Serum and synovial markers reveal SignalOme status. High interleukin-1 beta indicates active inflammation. Low insulin-like growth factor 1 suggests impaired regeneration. Elevated MMPs predict rapid progression. When available, synovial fluid provides direct SignalOme assessment. Interleukin-1 beta, over 10 picograms per milliliter, indicates stage 2+. MMP13 over 100 nanograms per milliliter suggests active catabolism. Cell count differentiates inflammatory arthritis. Serum markers offer non-invasive monitoring. COMP indicates cartilage turnover. CTX2 reflects type 2 collagen degradation. C2C shows collagen synthesis. The ratio predicts treatment response. MicroRNA profiling represents the future. MIR 140 levels predict regenerative capacity. MIR 27B indicates MMP activity. MIR 146A reflects inflammation control. Soon available as point-of-care tests. Interpret markers in context. CRP over 10 suggests systemic inflammation, addressed before local treatment. ESR elevation indicates chronic inflammation. Local markers matter more than systemic for joint therapy. Section 4. Bioelectric Assessment. Bioelectric assessment completes the evaluation. Bioimpedance reveals cellular health. Microcurrent testing shows voltage capacity. PEMF response predicts treatment success. Healthy cells maintain negative 70 to 90 millivolts. Inflammatory cells depolarize to negative 40 to 50 millivolts. Severely damaged cells approach -20 millivolts. Voltage predicts regenerative capacity. Create voltage maps of affected joints. Multiple measurement points reveal heterogeneity. Identify areas of severe depolarization. Target these zones for intensive therapy. Don't ignore systemic voltage. Chronic disease causes whole body depolarization. Poor diet reduces voltage. Dehydration impairs conductivity. Address systemic factors for local success. Section 5, Patient Selection Criteria. Ideal candidates share characteristics. Age under 70 with good general health. BMI under 35 for weight-bearing joints. Motivated for rehabilitation. Realistic expectations about timeline. Some remaining cartilage on imaging. Stage determines approach, not exclusion. Stage 1, excellent candidates, simple protocols. Stage 2, good candidates, combination therapy. Stage 3, challenging but treatable with aggressive approach. Stage 4, selected cases with specific goals. Recognize contraindications: absolute active infection, malignancy, severe immunodeficiency, relative uncontrolled diabetes, active autoimmune disease, litigation involvement, unrealistic expectations. Systemic health impacts local healing. Optimize thyroid function, affects metabolism. Controlled diabetes impairs healing. Address nutritional deficiencies. Manage sleep. Critical for regeneration. Psychology matters. Depression reduces compliance. Anxiety amplifies pain. Catastrophizing predicts poor outcomes. Address mental health for physical healing. Section 6, the master treatment algorithm. Now we integrate everything into the master treatment algorithm. This guides every clinical decision from evaluation to maintenance. Stage 1, early inflammatory protocol. Week 1, microcurrent normalization, 40 Hz for 15 minutes. Week 2, leukocyte poor PRP, 4 to 6 milliliters intra-articular. Week 3 to 4, daily PEMF, 8 Hz home therapy. Week 5 to 8, progressive rehabilitation. Week 12, reassess and consider maintenance. Stage 1 targets mild NF-kappa B elevation. PRP's insulin-like growth factor 1 restores balance. MicroRNA 140 rebounds within 4 weeks. Pain improves by week 2. Function normalizes by week 8. 85% success rate. Stage 2 catabolic protocol. Week 1, A2M 2 milliliters for protease neutralization. Week 2, PDPA 1 milliliters plus hyaluronic acid 4 milliliters. Week 3, leukocyte-rich PRP 6 milliliters. Week 4 to 8, daily PEMF 15 Hz. Week 9 to 12, structured rehabilitation. Consider second cycle of partial response. Stage 2 requires multi-target approach. A2M clears destructive enzymes. PDPA floods with regenerative signals. PRP provides sustained growth factors. HA maintains structure. PEMF ensures voltage coherence. Stage 3, fibrotic protocol. Week 1, A2M 2 milliliters plus microcurrent preparation. Week 2, PDPC 1.5 milliliters for anti-fibrotic signals. Week 3, WJ MSCs 30 million cells. Week 4, amniotic membrane micronized 100 milligrams. Week 5 to 12, intensive PEMF twice daily. Week 13 to 24, maintenance biologics monthly. Stage 3 demands anti-fibrotic focus. PDPC provides Dacorin and S-MAD7. MSCs secrete HGF and TSG6. Amniotic membrane prevents myofibroblast formation. Combined effect reverses scarring. Stage 4 salvage protocol. Week 1, high dose A2M 3 milliliters bilateral if needed. Week 2, PDPC 2 milliliters plus HA 6 milliliters. Week 3, WJ MSCs 50 million. Week 4, repeat PDPC. Week 5 to 8, intensive daily PEMF. Weeks 9 to 24, repeat cycles every 4 weeks. Realistic goal, functional improvement, not cure. Stage 4 requires honest counseling. Complete regeneration unlikely. Goal is delaying replacement 2 to 5 years. Improving quality of life, maintaining independence. Success is improvement, not perfection. Section 7, Voltage-SignalOme Integration Protocols. The Voltage-SignalOme algorithm represents our most advanced protocol, simultaneously addressing bioelectric and molecular dysfunction. Begin with voltage optimization. Measure baseline membrane potential. Apply frequency-specific microcurrent. 40 Hz for inflammation, 124 Hz for fibrosis, 396 Hz for regeneration. Achieve negative 70 millivolts before biologics. Match biologics to voltage status. Severely depolarized cells need PDPC's ionic content. Mild depolarization responds to PRP. Normal voltage allows any biologic. Voltage guides selection. PEMF parameters depend on stage and voltage. Stage 1, 8 Hz, 1 to 2 millitesla, 15 minutes daily. Stage 2, 12 Hz, 2 to 3 millitesla, 20 minutes twice daily. Stage 3, 15 Hz, 3 to 4 millitesla, 30 minutes twice daily. Stage 4, continuous 8 Hz overnight. Track voltage improvement. Weekly bioimpedance measurements. Correlate with symptom improvement. Adjust PEMF parameters based on response. Voltage normalization predicts clinical success. Sustainable healing requires home programs. PEMF mats for overnight therapy. Microcurrent devices for targeted treatment. Grounding sheets for passive normalization. Technology enables continuous therapy. Section 8. Rehabilitation Integration. Rehabilitation amplifies biologic effects, but timing matters. Too early disrupts healing, too late misses the window. Synchronize with molecular events. Phase 1 protects while activating. No weight-bearing first 48 hours. Gentle range of motion day 3. Isometric activation week 1. Maintain joint nutrition without stress. Phase 2 introduces progressive loading. Partial weight-bearing week 3. Resistance bands week 4. Pool therapy excellent option. Loading stimulates mechanotransduction pathways. Phase 3 restores function. Progressive resistance training. Balance and proprioception. Sport-specific activities. Build confidence with capacity. Understand mechanotransduction. Appropriate load stimulates insulin-like growth factor 1. Activates integrins for matrix production. Enhances stem cell differentiation. Movement is medicine when properly timed. Section 9. Monitoring and optimization. Structured monitoring ensures success. Week 2. Pain and function assessment. Week 4. Biomarker recheck. Week 8. Imaging if indicated. Week 12. Comprehensive reassessment. Use validated outcome measures. WOMAC for hip and knee. COOS for comprehensive knee assessment. VAS for pain tracking. Document improvement objectively. Biomarkers guide adjustments. Persistent interleukin-1 elevation. Repeat A2M. Poor insulin-like growth factor 1 response. Add PDPA. Rising MMPs. Increase PEMF frequency. Imaging lags behind clinical improvement. Expect symptom improvement by week 4. Functional improvement by week 8. Structural changes visible at 3 to 6 months. Patients required, modify protocols based on response. Partial responders need treatment intensification. Non-responders require diagnostic reconsideration. Early responders may need less aggressive approach. Section 10. Maintenance and long-term management. Regeneration requires maintenance. Joint degeneration is chronic process. Continued support prevents relapse. Think management, not cure. Maintenance options vary by stage. Stage 1, annual PRP. Stage 2, biannual PRP plus quarterly, HA. Stage 3, quarterly biologics plus continuous PEMF. Stage 4, monthly to bi-monthly treatments. Lifestyle factors determine durability. Weight loss reduces joint stress. Anti-inflammatory diet supports healing. Regular exercise maintains gains. Sleep quality affects regeneration. Specific nutrients enhance maintenance. Glucosamine 1500 milligrams for matrix. Chondroitin 1200 milligrams for proteoglycans. Omega-3s 4 grams for inflammation. Vitamin D 5000 IU for cellular function. Smart activity modification preserves gains. Low impact preferred over high impact. Cross-training prevents overuse. Proper biomechanics essential. Protect the investment. Section 11. Special populations and considerations. Athletes require modified approaches, accelerated protocols possible, more frequent treatments, enhanced rehabilitation, higher biologic doses. Goal: safe, rapid return. Elderly patients need gentle protocols, lower biologic volumes, slower rehabilitation progression, focus on function over structure, quality of life priority. Diabetes complicates treatment. Optimize glucose first. Higher infection vigilance. May need higher doses. Expect slower healing. Monitor closely. Previous surgery affects approach. Altered anatomy challenges injection. Scar tissue impairs distribution. May have metal interference with PEMF. Adjust accordingly. Section 12. Clinical decision examples. Case 1, 45-year-old marathon runner, stage 1 medial knee OA. Protocol, single PRP injection, 8 Hz PEMF nightly. Gradual return to running over 8 weeks. Outcome, full return to marathon at 12 weeks. Case 2, 62-year-old teacher, stage 2 knee OA, BMI 28. Protocol, A2M followed by PDPA plus HA, daily PEMF weight loss program. Outcome, 80% pain reduction, avoided knee replacement. Case 3, 70-year-old golfer, stage 3 hip OA. Protocol, A2M, PDPC, WJ MSCs over 3 weeks, intensive PEMF. Outcome, return to golf, 60% improvement in function. Case 4, 58-year-old bilateral stage 4 knee OA. Protocol, aggressive monthly biologics, continuous PEMF, structured rehabilitation. Outcome, delayed replacement by 3 years, maintained independence. Key takeaways. Let's consolidate your mastery of clinical protocols. First, comprehensive evaluation using structural, molecular, and bioelectric assessment identifies appropriate candidates and guides treatment selection. Second, stage-specific protocols address dominant pathology. One size never fits all in regenerative medicine. Third, success requires integrating biologics, voltage optimization, and rehabilitation in proper sequence. Fourth, regular monitoring with protocol modification based on response optimizes outcomes. Fifth, long-term success requires maintenance protocols tailored to disease stage and patient factors. Congratulations, you've mastered the art of creating personalized regenerative protocols. You can now confidently guide patients through their regenerative journey. Next, in our final module, we'll review the complete course, discuss CME requirements, and prepare you for clinical implementation. Let's assess your protocol mastery with 5 clinical questions. Question 1. For stage 2 osteoarthritis, what is the recommended sequence? Is it A, PRP then A2M, B, A2M, then PDPA plus HA, then PRP, C, MSCs first, D, steroids, then biologics? Question 2. Pre-treatment voltage optimization uses which frequency for inflammatory joints? Is it A, 8 Hz, B, 15 Hz, C, 40 Hz, or D, 124 Hz? Question 3. Stage 3 fibrotic OA requires emphasis on which therapeutic approach? Is it A, anti-inflammatory only, B, anti-fibrotic with PDPC and MSCs, C, surgical intervention, D, corticosteroids? Question 4. Ideal candidates for regenerative orthopedics have which characteristics? Is it A, any age with any BMI, B, age under 70, BMI under 35, motivated, C, only young athletes, D, only mild arthritis? Question 5. Maintenance protocols for stage 2 OA typically include? Is it A, nothing needed, B, daily injections, C, biannual PRP plus quarterly HA, D, annual surgery? Excellent. You've completed Module 7 and gained expertise in comprehensive treatment protocols. You now possess the knowledge to orchestrate complete regenerative programs. Remember, each patient's journey is unique, but the principles you've learned provide the roadmap. Your expertise can transform lives by restoring joint health through precision medicine.